the founder of Profi University.
Thank you very much. Distinguished guests, esteemed colleagues, honored delegates from Ruby Hall Clinic, Shah International Hospital, Tashkent Medical University, and the Walnut Group companies. Ladies and gentlemen, Assalamu alaikum, namaste, good morning. It is great honor and privilege for me to welcome you all in this historic occasion. The first Uzbek-Indian medical conference here at Profi University. Today marks a significant milestone on the journey towards fostering international medical collaboration and advancing healthcare excellence in not only in Uzbekistan, but also in Central Asia regions. First and foremost, I would like to express my deepest gratitude to our distinguished colleagues from Ruby Hall Clinic, India, for traveling this distance to share their expertise with us. Your presence here today demonstrates the universal commitment of medical professionals to transcend borders of in the pursuit of knowledge and a better patient care. I extend my sincere appreciation to our exceptional speakers who will grace this stage today. Dr. Purvis Grant, our esteemed cardiologist, who will discuss contemporary approaches in clinical cardiology. Dr. Himish Gandhi, specialist in robotic urology and uroonkology, who will enlighten us on modern, minimally invasive surgical techniques. Professor Boymurodov Shuhrat Abjaliyevich, Rector of Tashkent State Medical University, who will share insights of surgical treatment of vascular deformities. The Dr. Chokawara, our oncology expert, who will present our contemporary oncological treatment strategies in clinical practice. Professor Rizayeva Sevara Mirglovna from Profi University, who will discuss modern orthopedic treatment approaches for patients with facial defects. Dear speakers, your dedication to medical education and your willingness to share knowledge is truly commendable. I also to thank you, our university and Shah International members, medical students, and all participants who have made this conference possible with a hardworking and commitment. Dear guests, healthcare knows no boundaries. The challenges we face, whether in cardiology, oncology, neurosurgery, or other fields of healthcare, are universal. However, the solutions, innovations, and approaches can vary significantly across different healthcare systems and geographical regions. This is precisely why today's conference is so valuable. The collaboration between Uzbekistan and India in medical field represents a meeting of two rich traditions of healing and innovation. India has emerged as a global leader in medical tourism, advanced surgical techniques, and affordable, high-quality healthcare delivery. Meanwhile, Uzbekistan is rapidly modernizing its healthcare infrastructure and medical education system, eager to adopt international best practices. At Profi University, we have always believed that in medical education requires exposure to global standards and international partnerships. Today's conference is a testament to commitment and starting point of great medical collaboration. This is just beginning. I envision the first Uzbek-Indian medical conference as the foundation of an ongoing partnership that will grow stronger with each passing year. Together, we can elevate the standard of medical care in Central Asia and contribute to global medical knowledge. Once again, thank you very much, dear colleagues, guests, and special gratitude goes to my parents, my wife, and my team, and all you participants. I'm glad to have you. Thank you very much.
Good morning, everybody, and thank you for your hospitality today. We've traveled a long way to come and be with you, and we look forward to taking this project forward. We want to partner with this university and produce something really great from it. I know we are all charged up to do something nice and great, but I can promise you that Ruby Hall and this university will move forward to greater things. As far as Ruby Hall is concerned, let me tell you something about Ruby Hall. Ruby Hall started nearly 70 years ago by my father, and it was a two-bedroom hospital, as I call it. From two-bedroom, we have now grown to 900 beds, and we are today one of the most modern hospitals in the whole of India. We have 5 hospitals in the city of Pune, and we are building the 6th hospital now. We employ nearly 4,500 people who work at Ruby Hall. And the main thing that we want about Ruby Hall today is it's structured as the most modern hospital in the whole of India today in technology. So I'm going to talk about the technology that we have brought in. Not only do we have main Ruby Hall, but we have many units all around the state, including all these various cities, all with MRIs and CT scans. We've got total 4,500 people, and Ruby Hall specializes in cardiology. We did the first angioplasty in India in 1987. I don't know if you all know what is angioplasty. Angioplasty means when you have a blockage in the artery of the heart, you put a balloon and open it up. So the first angioplasty in India was done in 1987. Since then, we have completed 160 oncology or cancer center in the country. We have more than 200 ICU beds. So you can see that Ruby Hall is one of the largest hospital groups in India. We specialize in cardiology, as you can see. We have done more than 45 heart transplantations at the hospital. So this is the angiography unit or cardiac angiography setup. Now, why is this setup important? This setup is important because if for any reason you have a complication or something goes wrong, you can convert the angiography setup into a theater and you can operate within 5 minutes. So you don't have to move the patient out. So this is a huge advantage that we have at Ruby Hall Clinic. And very few hospitals have this special type of cath labs. We have these special theaters available also for spine surgery, thoracic surgery, brain surgery, and so on. And this, you can see, this is what the angiography looks like. That is a normal angiography of the heart, where you've got all clean arteries. And you can see here there is a stent or a spring put in. So when you have a blockage in the artery of the heart, to keep the artery open, we put a little spring. The spring is called a stent. We can also find out how the stent has been implanted properly. So we can get beautiful pictures like this. So we have got what is called as dynamic coronary angiography. So we can actually see how the wire goes in. So you can see that wire is going right inside the artery of the heart. It's going down, and you can exactly pinpoint where you want to go. So we have got this new thing called dynamic angiography, where we can actually go into the arteries of the heart, and then once we are there, we can do the angioplasty. We also have what is called as intravascular ultrasound. That means you can put a probe in the artery of the heart and actually see where their blockages are. So this is a normal artery and this is the diseased artery full of calcium. So you can see these beautiful pictures like this, you can see, of the coronary arteries. And this is a well-apposed stent. You can see that that's the spring, and this is a mal-apposed stent. That means the stent has not been implanted properly. So then you need to go in and re-put the balloon and open up that artery. We have got what is called as TAVI procedure. TAVI means trans-aortic valve replacement. So in the past, 15 years ago, when your aortic valve was narrowed, that the valve was narrowed, what we used to do, we used to go in, cut the chest and put an artificial valve in. The artificial valve used to last for up to 20 years, 22 years. Nowadays, we don't do this anymore. What we do is a TAVI procedure, or we put a stent in the valve itself. You can see that that's the valve, and that is a stent going inside. So without cutting the chest, we go from the femoral artery. We have done 5,000 such patients. So we don't need to cut the chest anymore. So this is a big advantage. It is called as trans-aortic valve implantation, or TAVI procedure. So this is a new procedure also being carried out at Ruby Hall. And you can see that this is the aorta. And in the aorta, we have put the new TAVI valve. So this is what the procedure is all about. That's the aorta, and there goes the TAVI valve that goes into it. So there is no surgery, no cutting of the chest. So this is a big advantage that we find in patients. And here again you can see this is the aortic valve, and that is the TAVI procedure which is fitted there. This procedure takes only about 40 minutes. Next morning the patient goes home, and the TAVI lasts for at least 15 years. So this is a great procedure that we are now doing at Ruby Hall. We also have a new technique for brain. So we have got what is called as a stroke protocol. Stroke means one of your hand or one of your legs suddenly doesn't start working. In that situation, we have a biplane special cath lab. That means there are two planes like this. We take the person into the cath lab, and then where the clot is, we find the clot and we suck the clot out so that the stroke doesn't progress and the patient becomes normal. We can also put stents or springs in the brain. So even this technology now is available at the Ruby Hall Clinic in Pune. Very few hospitals in the world do that. So we have taken Ruby to the technological peak of the world today. I know my colleague 1 month ago, he was in charge of this cath lab, same lab, suddenly developed loss of his hand and loss of his leg. Within 15 minutes, he came to Ruby Hall Clinic. We did an MRI. We found that he had a minor stroke. We went inside. We sucked out the clot. And 3 days later, he came back to work and started working again. So this type of technology now is available in the city of Pune and Ruby Hall Clinic. And soon we should bring it here too. So you can see this is the technology I was talking. That's a spring in the heart, in the brain itself. So the brain has got a spring over there which has kept the spring open. So these are the type of things. This is an aneurysm which we closed, which is there, aneurysm. We removed the clot without surgery. You see, that's a big swelling in the brain, and that's gone. So these sort of things are going on now at Ruby Hall. Now in 1958, when somebody needed a pacemaker, we had to cut the chest and put the pacemaker in. Sometimes the pacemakers were 6 inches big. So we had to make a big incision, put it in. It was a big surgery. Nowadays things have changed. The pacemakers have become smaller, smaller, smaller, and now it is the size of just this size. And it's like a bullet. So you see this? It's just like a bullet, and you shoot it in, Once you shoot it in, it takes about 15 minutes, no cutting, no pocket, nothing. The pacemaker just goes in. Where is this slide? Oh, so we'll just go back. So this is the new leadless pacemaker I was talking about, where you just shoot the pacemaker. Now, at Ruby Hall last month, we have done a patient where we have paced both the atrium and ventricle using the new technology. So you can put one lead into the atrium, one lead into the ventricle, no pocket at all, and the patient goes home the next morning without any surgery. So this is the leadless pacemaker that we have got. We've also got a special machine which we have installed, and this is for cardiac laser. So what happens is, and after 10 years or 15 years, the stent or the spring is blocked or gets blocked. We can take the laser and put the laser in and completely open the stent or the block without surgery and not put another stent in. So you can see this is the new machine that has been installed. It's low wavelength. And this is a patient whose stent has got blocked. You can see over there. And then what has happened, we have opened the stent completely with using the new laser. So we have not put another stent. We have just put the laser in, lasered it, and within 20 minutes the artery is fully open. So we can do things like this, which very few hospitals are able to do. And this is the cardiac laser I was talking about, and that's the laser cutting the atheroma and opening it up. So this is a laser atherectomy, which we have installed about 6 months ago at the Ruby Hall Clinic in Pune. Full spectrum of morphology. Atherosclerosis can be completely open. We can cut calcium also and use it for restenosis. So this is the laser going, photoablation, completely goes, opens the artery and improves the vessel. So this sort of things are now possible in Ruby Hall Clinic. So photomechanical. We've also got what is called as the CyberKnife technology. Now, CyberKnife is a new machine, a new technology. There are only 2 machines in the whole of India also. What CyberKnife does is that if you have a cancer, then it will kill only the cancer and not damage the tissues around it. For example, if you've got a tumor in the ear called acoustic neuroma, what people have, the present treatment is surgery. You go in, operate and take out the tumor. In Pune, in Ruby Hall, what we do, we simply take this new machine, CyberKnife, and we take the patient into the CyberKnife room. It works on complete AI. And we simply put the beam on, 20 minutes, he comes out of the machine, the patient is completely cured. Similarly, trigeminal neuralgia, where you've got the trigeminal nerve is very active. You can also use it for trigeminal neuralgia. If you have a tumor in the brain, very close to the eye, you want to protect the eye and not damage the eye, so you can use this. We have done 950 patients already with this new technology, and this technology is very, very advanced. What has happened? Okay. Have we missed something? Okay. So we also have what is called as the new Da Vinci robotic system. We had the old Da Vinci robotic system at Ruby Hall, where we have completed more than 1,000 patients. Now this is the more advanced system that has come in about 2 to 3 months ago. We are doing 2 to 3 operations on this. The great advantage of this is there is no incision. It's very good for abdominal surgery, some type of prostatic surgery. So this advanced treatment is now also available for your patients. It's also got a lot of gynec applications for tumors removal in the stomach. So this new technology is also available, and without any cutting of the patient. So again, next day the patient goes home with this advanced robotic system. We've also got RASM, but my colleague is going to talk about RASM, so I will not talk much about it. It's mainly used for prostatic surgery. I'm sure Dr. Gandhi is speaking next, so I won't go into this particular area, but it's a very beautiful system. We have got Modulith, the most advanced treatment for kidney stone, so we can break kidney stones without damaging the kidney. I'm sure Dr. Gandhi will also talk a little bit about it. We have the most advanced laboratory system in the world, where we can do 1,500 tests a minute. So this is a complete laboratory system which has been now installed at the Ruby Hall Hospital. We have what is called as digital PET system. That means it's a system to pick up very early cancer. So the person goes into this PET system, digital PET, and you can pick up very early cancers, which is picked up very early and then treated. So we have got the most advanced digital PET system, and we'll be the only hospital in India to have 2 PET systems. The new one is just getting installed at the moment. So we'll have 2 PET systems for very, very early diagnosis of various type of cancer and treatment as well. 1 year ago, we installed the world's fastest CT scan or CAT scan, as you know. A normal CAT scan works at 150 cycles per minute. This one works at 1,150 cycles per minute. And you're going to ask me, what is the advantage of having such a fast scanner? Well, the great advantage of this scanner is that it can do a full cardiac CT scan in 10 seconds. So you don't need to do angiography anymore. You don't need to go to the cath lab and do an angiogram at all. You just put the patient in the CT scan. This is the first machine in the whole of Asia. It comes from Siemens of Germany. And the main advantage is, number one, no sedation is required for children. Children just go inside 1 second and they come out. So there's no need of any anesthesia for the child, which is a great advantage. Number two, you don't need to give a beta blocker to slow the heart rate down. It can do it at any rate. Number three, the radiation is like only taking 2 X-rays instead of the old technologies, which is 40 X-rays. And number three is that the dye that is given, instead of 100 mils, we can do it in only 20 to 30 mils. So it's a big advantage using this new CT scanner. The CT scanner has become very popular, and we are getting patients from all over the world, from Singapore, from Dubai, from Africa. One patient came to Pune from Canada, another one from Australia for the CT scan. So this is the new technology that is now available. This is the first machine in the whole of India. And you can get, this is a picture of the brain. You can see such beautiful pictures of the brain using this new technology. This is an aortic stent, that is a stent in the aorta. You can see it so beautifully, like the stent over there in the aorta. You can see the renal arteries, how beautifully they are shown. This is the kidney arteries with this new technology. Beautiful pictures. And this is the heart. You can see the heart so beautifully demonstrated. Each artery is very well demonstrated. You can see these beautiful pictures as if the heart is like an anatomy book. So you're getting these type of pictures which are never seen before in medicine. So this is a surgeon has done a bypass graft. So you can see that's the aorta. From the aorta, each and every graft that the surgeon has put in, you can see. So this is from the aorta, the grafts that are put in, again the graft. And look at the clarity of the grafts. You can also make out whether the grafts are working or not working. So this is a huge advantage of using this new technology that is now available in Pune city. You can see the leg arteries, beautifully demonstrated. Each leg artery you can also see. And this is without putting a catheter, without putting a tube. You're getting pictures like this, totally non-invasive. Again, this is a lower limb. You can see the pictures. This is the heart again. And you can see these are the little blockages coming up in the arteries. You can see the calcium. There's a bit of these white specks. This is all calcium that is seen in the arteries of the heart. And then you can actually measure the calcium, how much the calcium is and whether you need to do anything further. So this is again the arteries. This is the arteries going to the brain. How beautiful pictures you can see. And this is a child having a CT scan. He just goes in the machine and comes out within a few seconds. So there is no anesthesia. These are some more pictures. You can get beautiful pictures like this using this technology. This is a partial anomalous pulmonary venous drainage or ASD. You can see the aorta. The aorta is completely blocked over down. There's no flow below that to going to the leg. So you can see pictures like this. This is an emergency and needs urgent intervention. So you can see the aorta and no blood going down. The aorta is the main pumping chamber which is coming out of the heart. And here you can see what is called as a dissection of the aorta. That means the aorta is torn. You see, that's the aorta and there's a double shadow there. You've got one shadow here, one shadow there. So there's a double shadow over there where the aorta is completely torn. And when you get these people, you are all medical students, aorta dissection normally presents with pain in the back, not so much in the chest. When you get pain in the back and the patient is deteriorating, you must operate within 6 hours. If you don't operate within 6 hours, this patient is going to die. If you operate, the success rate is more than 80%, but it has to be done soon. It has to be picked up soon and operated soon. I'll show you, this is a child with a tumor which we did, and you can see there's a large tumor in the abdominal area of the child. Again, no anesthesia was used. These are the brain pictures. This is in the ear. These are the lung perfusion studies you can also do using this new technology. This is the fat estimation of the liver. We are getting a lot of fatty liver nowadays, and you know fatty liver leads to cirrhosis. So you can pick up this fatty liver early, and there are new treatments available. This you can also pick up gout. This purple thing that you see is gout that has been picked up in this new technology, where the uric acid is high. So you can see beautiful pictures like this, where the uric acid is high using this new technology. This is lung perfusion, and you can see virtual bronchoscopy. So instead of putting a tube in the bronchus, you can take the patient, put him on the CT scan and see you've got a tumor right in the bronchus. So virtual bronchoscopy without using a bronchoscope. So this is the new technology also that is now being developed more and more. This is again stomach. You can see gastroesophageal reflux. That's the stomach, and that is showing gastroesophageal reflux using this new technology. So you don't need to do a barium swallow, any of those old techniques. You just put the patient in this machine and you'll get pictures like this. So, what is this? Okay, this is a new device we have for getting the creatinine. So before we do a CT scan, we always check that the patient's creatinine is normal. So we have this device that can give you the creatinine within 1 minute. The patient just takes a tiny piece of blood and you put it in this machine. So you don't have to waste time. The patient comes, gets his creatinine done, goes straight in the machine. Within 10-15 seconds comes out, the report is given to him, and that's the technology you have today. We've also got the fastest MRI in the world at Ruby Hall Clinic. And this is installed about 6 months ago. And it has got what is called as smart speed. Why do you need to do it so fast? You need to do it so fast because nobody wants to be in an MRI machine for 40 minutes and 50 minutes. So we bought this new machine, again the first in India, which has got smart speed technology. And what this machine does, it gives you excellent quality, but more than that, for a knee which used to take 25 minutes, we do it in 7 minutes. For a prostate, 40 minutes, 12 minutes. For an MRI stroke, 3 minutes. So we have brought the time down from 45 minutes to 5 minutes and 6 minutes using this new technology. This is a very advanced technology, and this is for the first time in India, again, has been installed at Ruby Hall. We can do MRI elastography, which is very good to pick up fibrosis of the liver. So we can treat the fibrosis of the liver, because now there is a new treatment available for fibrosis of the liver. There are some new tablets which have come out, so you can start using these tablets. This is showing a low-grade glioma. So we get beautiful pictures like this on the new MRI. So this is a carpal tunnel syndrome, which is there on the MRI. Vascular. This is HOCM, hypertrophic obstructive cardiomyopathy. So you can see this is the heart, and the heart muscle has become thick, and this is called as HOCM, hypertrophic obstructive cardiomyopathy. You can pick up these things very soon and start treating them, because even for this there is a new tablet that is available now, and it can cause regression of the hypertrophic cardiomyopathy. The old treatment was you used to inject alcohol into the first perforator and cure these people. But nowadays there is a tablet available which can be used for these people. So this is hypertrophic obstructive cardiomyopathy, which I spoke about. Cardiac sarcoidosis, you can see sarcoid. So all these things you can pick up. This is amyloidosis on the MRI. So these are the things which we used to miss early. This is constrictive pericarditis. You can see constrictive pericarditis, which we used to miss. And again, we can pick up these constrictive pericarditis. This is ARV, that means arrhythmogenic cardiomyopathy. So this needs to be treated because this can cause sudden death. Things like this are also needed and picked up early. You can see there is a mass in the heart here, a large tumor there. So these tumors can also be picked up using this new technique. We are the first hospital in Asia to have our own cyclotron. Now, what is a cyclotron? Cyclotron is a very complicated machinery that produces, that is used for the PET scan, and that produces FDA, which is produced in the PET scan. So this cyclotron is for the first time. Because of this cyclotron, Ruby can do all these various complicated tests like ammonia, PET, DOT, GABA, so on and so forth. So this is a very advanced technology. This cyclotron comes from Sweden. It comes with, it's very radioactive. It comes with 100 tons of concrete around it. It comes in trucks from Sweden. Then it is installed. And in addition to that, there are 12 feet of bunker. That means the bunker thick is 12 feet. So it has a bunker first, 12 feet thickness walls, and on top of that you have this concrete comes from Sweden so that there is no radiation leak. It's basically like an atom bomb. So you have to protect everybody and around it. But we have installed this machine at Ruby, and because of this, we are able to get this FDG, which is produced in-house, and now we are sending it to other hospitals as well. So this is the cyclotron. First cyclotron installed in the whole of India. This is another machine for prostate. Dr. Gandhi is going to show you and talk to you about it. It's a very advanced technology. This is started only 2 months ago, 1 month ago actually. We've also got the best PET scan in Asia, is just getting installed. This is a Chinese equipment. I can find a lot of Chinese cars in this country today. So they've landed up in India as well. So we are advancing this new technology. So this is called as Pan Vision, and this is the new PET scan that is getting installed. We've also got the most modern operating theaters. Dr. Gandhi will show you some pictures about these theaters as we go along. But this is the latest technology that is available. Because of our traffic problems in the city of Pune, we are now using scooters to give the first aid when an ambulance call comes. So the scooter goes with the defibrillator and everything, goes to the patient, and then the ambulance follows once the traffic eases. We've also become completely paperless. The whole hospital has become completely paperless, and everything is available on an app. So from the app, you can see where to park your car, to the time you go to your room, everything is online and app-based. We've also got for diagnosing early cancer, especially the stomach, where we have got this new technology called CARI that tells us where the cancer is so that the surgeon knows and takes the biopsy only from that part rather than a wrong part of the body. So this type of thing, you can see this patient was bleeding, Mallory-Weiss syndrome, a big clip. So we went and clipped the bleeding and the patient was cured. We've got luxury suites so that the patient is very comfortable when he comes to the hospital, just like the Ritz-Carlton or any good hotel. So we want to make the patient as comfortable as possible when he comes to our hospital. So this is a special area which we have. This is nothing to do with the hospital. This is a management building where we manage all the facilities, including generator, backup, water treatment plants, administrative services, sewage plants, to keep the hospital running shortly. We are building our 6th hospital now. It's a 300-bed, and mostly it will be a cancer hospital. So this hospital is just coming up in the city of Pune. This is the 6th hospital, and hopefully we'll have the 7th hospital in Tashkent. One more important thing, this is a charitable trust. The hospital is not there to make money unlike other hospitals in India. Whatever the hospital earns goes back into the hospital for equipment and to help the poor people. So this is not a hospital for earning, it is a hospital for giving, remember that. So we do a lot of charitable work. We do about $2 to $3 million of charity every year. All children below the age of 16 who have cancer are treated completely free of charge. So remember, this is not a commercial hospital. We have done open heart surgery on children that are only 4 days old and send them home. So this is for underprivileged children. This is the Prime Minister of India, and that's me. This little girl wrote to the Prime Minister and said, I have no money, can you please help me? The Prime Minister wrote back and called Ruby Hall and says, please get this surgery done. And when he visited Pune, he said, call the girl, I want to talk to her. And this girl has now become a policewoman, not man. So she's become a policewoman. Ruby Hall has got its own metro station. The whole station is named and is touching the hospital, so that 30–40% of our staff now comes by metro rather than parking the cars, because we have a parking problem. So this is a big advantage of Ruby Hall. We do a lot of good work. In COVID, at one stage, we had 120 patients on ventilators, and we have treated nearly 8,000 COVID patients during this period. We have done, as I said now, 43 heart transplants. This is a little older slide. We've done renal transplant. Liver transplant is one every alternate day. So this is the team that has come. I don't know if you know, there's a company called Danube in Dubai, very big builder. He wanted to get a CT scan done, so he got 10 of his employees, put them on a plane in Dubai, flew down, did the CT scan, and 3 hours later, he flew back to Dubai with all his reports. I have been also now become advisor, National Commission for Minority Commission for the Government of India. They have appointed me and given me this very great honor. I want to thank you for this presentation. I hope you've learned a little bit about the new technologies that are now available in the city of Pune and in India, so that we move forward. Thank you very much. Thank you.
On cardiology.
I'll talk on that straight away. Oh.
Thank you very much for this informative and insightful presentation.
Excuse me, can you speak with a little bit pause? There is a translator here. Is there?
Oh, a little slower.
Yeah.
Okay.
So that English they'll
Yeah.
understand.
I'm going to give my second talk on the future of cardiology, what is happening in cardiology and what has happened in the past in cardiology. This is something new that we should all know about. So, if you go to the history of cardiology, the first angioplasty was done, or the balloon treatment was done in Bern by a professor called Professor Grunzig. He did the first plasty, and what he did basically was, there was a blockage in one of the patients. He took a balloon and put the balloon in, opened the artery and came out. That patient is still alive, which was done in 1977. The professor who did the surgery, Professor Grunzig, unfortunately died because he became very famous. He was taken over to America. He bought his own plane. He was flying his own plane and died of a plane crash. So the first person who had angioplasty is alive, but the person who did it has unfortunately passed away. Then in 1986, what used to happen when angioplasty first took place, the restenosis or the reblockage rate was nearly 30% because there was nothing to hold the artery open. So what used to happen, that 30% of the patients used to block off, sometimes immediately and sometimes in a short time. So angioplasty got a bad name. People said, "Arey Baba, angioplasty is too dangerous, don't go for it." Then in 1986, the stents came out, or the springs. And initially we had the bare metal stents. That means you had a balloon, and over the balloon you used to put this metal, please keep it open and put it in. That also gave trouble because the restenosis rate was about 6 to 7% with that. It was not so good. Then in 1999, the drug-eluting stents came. Drug-eluting stents means the stent had a drug coated into it, and because of that, the restenosis rate came down to 1%. Then things got even better. Now the restenosis rate is around 0.1%. So it's a marked technology that has taken place over a period of time. So you had the plain balloon, then you had the stents, then came the drug-eluting balloon, then the further drug-eluting balloon came in, and there you can see the technology. And a lot of people tried a lot of different things, a lot of different materials to use. And then came the cipher stent, the taxus stent, and this is the polymer. You can see that in the polymer, is damaged in some cases. So things were not very good as we progressed. Then things got better and better and better. Now the plain stents are gone and all the stents are now drug-eluting. But cardiology is not only stents. You can see now here there is a blockage over there, and we can actually measure the blockage, how much the blockage is there. Here you can see, it's very rare that, in fact we picked this up, this is going back 25 years ago. When we first started putting the stents, you can see the stent itself was damaged while manufacturing it. But nowadays we don't see this anymore because it's all done on a computer. So 50% of deaths don't even reach the hospital before they can do the angiography or angioplasty. So there is a lot of new technology come. I won't go into too much of it, but we have got what is called as carotid Doppler, where we can actually measure the thickness and find out very early whether the patient has got coronary artery disease or not. So this is one of the diagnostic tests. We don't use this so much nowadays. But intravascular ultrasound, where we actually take a probe and put the probe in the artery of the heart, we can then get beautiful pictures like this, whether there is any calcification, whether there is any blockage. We can see whether there is calcium, fibrous or fibrolipid plaques in the coronary arteries. So you get beautiful pictures like this. You can see See, this whole artery has got practically 75-80% blocked. So this type of things you can see in the coronary arteries. So you can see pictures like this. We've got now 3D echocardiography where you can see the valves if there's any problem. We've also got 4D echocardiography now where we get even better pictures than this. Like you can see, this is the ulcerated plaque in the coronary artery. So these are the various plaques you can see in the coronary artery. And things are getting better and better and better. Now you can see here, this is a large aneurysm. This patient actually came to us from Iraq. You can see there's a large, this is the aorta, large aneurysm, and we have put a stent in the aorta. So you can completely stent the aorta as well. So you can see such a beautiful stent in the aorta. Patient is completely cured. Here again you can see the stent in the aorta. That's the aorta with a beautiful stent right in the aorta. This PET I already spoke about, so I won't spend too much time on the PET scanning, but this is the latest technology. Now this is the viability. So you can do the thallium stress test and you can see this part of the heart is viable and that part of the heart is not viable. So these sort of things are also important to determine whether the patient should go for surgery or not go for surgery. This is another technique which is now available at Ruby Hall where you've got a cancer. You can see the patient is studied with cancer and this is picked up on the whole body scan. Again, the patient has got massive amount of cancer, the black thing. Now we have also got a new treatment called CART, which we are using at Ruby Hall. Patients who have got stage 4 cancer, especially of the prostate, we can use this new treatment and completely destroy the cancer. And we've been following these patients for 3 years now, completely cancer-free, especially patients with cancer of prostate. Now we are trying this technology on other cancers like breast and other areas. So this is the brain showing some treatment. I already spoke about cardiac MRI, so I won't spend too much time about it. But you are getting HOCM, as I spoke to you about myocardial necrosis. You can pick up again where the heart is getting lack of blood supply. Electrophysiology is another area where we are doing a lot of work. And if you've got supraventricular tachycardia, we do an electrophysiology study and we ablate the area that is giving trouble. And we are getting a lot of patients for this. So this is the ablation catheter that is used. And we simply go and ablate it. And the next morning the patient goes home and the arrhythmias are completely removed. So we do a lot of pacemakers, a leadless pacemaker. Now this is another technology where we are using a lot is when we have a hole in the heart, like an ASD. We close the hole without surgery. You can see this device which comes like it's called the amplexer device. So we don't do, if you have a hole in the heart like an atrial septal defect, all these are closed without surgery. And this is the device. It takes about half an hour to close. And you can see this device is used to close this. I spoke about the aortic valve replacement. This is an aortic valve where we are using the special stents. And you can see that this aorta is being closed without surgery. And that's the technique that is used. We are also using this for mitral valves now. So if you've got a mitral valve that is leaking, you don't need to go and do surgery anymore. The mitral valve itself can also be repaired without cutting the chest. So this is another area where we specialize. It is called mitral valve clip. So this is the techniques that are now available, and you can see how the mitral valve is clipped without again cutting the chest. So friends, there is a lot of new technology coming out in cardiology. A lot of new things are happening and we have to keep up upgrading ourselves to keep up with all this technology. So what cardiology was initially 30 years ago and what it is today is completely different. Nobody hardly uses the stethoscope now. It's all echocardiography, angiography, CT scan, MRIs, and so on and so forth. That's why I just wanted to update you on what is happening in the real world as far as cardiology is concerned. Thank you very much. Thank you.
experience, and knowledge with us.
İlk navbatda Hindistondan tashrif buyurgan davlat hukumati mehmon speakerimizni sahnaga taklif etamiz. Doktor Hind Gandhi, tibbiyot fanlari doktori, professor, robotlashtirilgan va minimal invaziv jarrohlikda zamonaviy klinik amaliyot mavzusida taqdimot qiladi.
Next, it's our pleasure to invite another respected guest speaker from India, Dr. Hind Gandhi, Doctor of Medical Science, Professor, who will present on modern clinical practice in robotic and minimally invasive surgery.
Good morning, Salam Rahmat. I'm Dr. Gandhi. I am in charge of robotic surgery and now recently included to our armamentarium is robotic HIFU technologies. Once again, I thank Dr. Parvez Grant for delivering such an excellent lecture, and to see that in a single lifetime he has achieved so much and brought Ruby Hall to a level where it competes with one of the best hospitals across the world like Mayo Clinic, Cleveland Clinic, UCL London, and quite to be privileged to be a part of this family. And his new plan is to set up a hospital here in Tashkent. So we are very much glad to be part of this medical facility here. So Ruby Hall has a legacy to be the first in everything, and right now with the facility what we have, we are among the best in the world. I was specifically trained in Singapore for my robotic surgery, and sometimes I talk to him that we have more facilities than I used to have in Singapore. So again, a round of applause for him for understanding us and bringing the best at our disposal. So robotics, we are aware that we start seeing from the animation, we saw some movies, and now we have a real-time experience of robotics. In humans, we have a lot of robotic influence. You name it, as a bedridden patient using robotized machinery to get up from the bed. Even in ICUs, people are using robot for teleconfrontation. So now, when we talk about surgery, the things are moving. Previously, there was a saying that big surgeon make big incision, but no, now it is not the understanding like that. The understanding goes as more of an organ preservation rather than removing the complete organ. So all these factors do help us to understand why this technology advancement is required. Why somebody wants to have such big scars when we do it everything with the minimally invasive approach? Whether the minimally invasive surgery is acceptable or it has some problems as compared to open surgery, we have sufficient data that all parameters are checked in: pain score, blood loss, vision, clearance, everything, the minimally invasive scores over it. So when we talk about minimally invasive, it comes to our mind, what will be the best thing, whether laparoscopy and robotics. And I was very glad that one of the Shocks hospital has a Da Vinci SI robot, which I saw on the way. The advert was going on. So I'm quite happy that, okay, robotics has already infiltrated the Uzbekistan healthcare facility. Why robotics? Why not laparoscopy? The answer is very simple. You cannot break your bread with the help of a chopstick, right? So laparoscopy is exactly like chopsticks. To break a bread, you require your hand. Similarly, for robotics, where all the internal organs are three-dimensional organs, we require something which is more flexible, which gives more precision, and which helps us to make the desired incisions, suturing wherever we require. That is why this is robotics, where it gives the dexterity of human hand. What we do at Ruby Hall, in just video. So this is the robotic surgery department. What we have the Da Vinci XI robot, And this is routinely what we do at our center.
Surgery, consistently delivering precision-driven care using the Da Vinci robotic platform. With a legacy of more than 1,000 robotic surgeries performed over 8 years, that journey evolves further with the upgrade to the latest and most advanced Da Vinci Xi system. The Da Vinci Xi represents the next generation of minimally invasive surgery, designed to enhance surgical precision, control, and patient safety across a wide range of complex procedures. This advanced robotic system is used in the treatment of thoracic diseases, such as lung and thymus cancers, urological conditions including prostate and kidney cancers.
But it gives us a more precise and a more organized plan to treat prostate cancer. All men who are diagnosed with a prostate cancer doesn't require removal of the prostate. That is the take-home message. You diagnose it early, you stage them properly, and you save the prostate because of obvious reasons. This machine gives us the flexibility of doing either a focal ablation where the disease is only in few of the cores. We can treat half of the prostate, or we can do a near total ablation of the prostate. Similarly, this is also for the first time where Ruby Hall has introduced something called as integrated operation theaters. How does it work? I'll just show you through it. Advanced healthcare management. With this, I would like to thank you all once again for your patient listening. And if you have any questions, our team will be more than happy to answer. Thank you once again.
Your experience and practical insights are truly valuable for all of us.
Assalomu alaykum. Hurmatli bugungi tadbir ishtirokchilari, hurmatli mehmonlar, hurmatli talabalar, yoshlar, hamkasblar, barchangizni ko'rib turgandan xursandmiz. Profi Universiteti, demak, Toshkent davlat tibbiyot universiteti bilan birinchilardan bo'lib, demak, hamkorlik shartnomasini imzolagan universitetlardan biri. Mana shu Bektosh Xatamov mana u nafaqat yaqin do'stim, balki bizni demak hamkorimiz. Shuning uchun biz mana shu konferensiyani taklif qilgan paytda men borib ishtirok etaman deb o'zimga ahd qildim va barchangizni ko'rib turgandan xursandmiz. Hozir men so'radim, qaysi tilda ma'ruza qilsam yaxshi desam, o'zbek tilida boshlayman, slaydlarim rus tilida. Agar ruxsat bersangiz, ingliz tilida davom etaman yoki tushunarli bo'lsin desanglar, ikki xil tilda yoki bo'lsa uchta tilda shunaqa davom etaveramiz. Shuning uchun barchangizni ko'rib turgandan xursandmiz. Men o'zim shu lavozimda bo'lishdan qat'iy nazar nimada o'zim xirurg sifatida, ya'ni yuz-jag xirurg sifatida har kuni operatsiyalarni amalga oshiraman. Bu asosan jag yuz sohasini murakkab deformatsiyalarini to'g'rilash, ya'ni shu jag'larda bo'layotgan tug'ma, orttirilgan anomaliyalarni davolashga bag'ishlangan shu ma'ruzam. Bilasizlar, mana jag deformatsiyalari juda ham ko'p deformatsiyalar, ya'ni stomatologiya fakulteti yo'nalishi talabalari bor uchun aytaman, jag'da prekurslarning buzilishlarini 3 xil toifasi bor. Birinchi, ikkinchi, uchinchi sinfi bor. Uchinchi sinfda umuman katta deformatsiya bo'ladi, ko'proq tug'ma bo'ladi. Dear guests, I would like to give small information about my surgery. I'm a rector of Tashkent Medical University. Also, I'm a maxillofacial surgeon. I do my surgery every day because I like it. My surgery about today I would like to present for your attention about the jaw deformities. What is jaw deformities? Usually third class young peoples who suffer this pathology, and about 80% from them they come to a surgeon to correction this jaw. What kind of clinical things? At first it's visual, aesthetic. After that, the discomforts of chewing. Also, the problems with the there is a lot of surgical methods of correction jaw deformity. You can see the method of vertical osteotomy, and from 100 years ago it was creating some methods. Still it going to improve, and the main tasks or orientation in this surgery is a right position of the dental arch. Also, the like method of correction with the vertical osteotomy. You can see here, this is very the famous. Nowadays, this coming to improving this method, we visualize before the surgery with the 3D dimensional. After MSKT surgery, you can see here a lot of types of surgical methods. And nowadays, before the surgery, not only the jaw deformities, but soft tissue, thanks and visualizing the before the surgery. Also, the transposition of the jaws coming to changes of aesthetic ways of patients. And now, before the surgery planning, we do splint tubing on the models of the jaws. You can see here the equipment of bioprints, which will print surgery before the surgery planning and splint, and like splint before surgery. On the model, we realize the surgery design. After that, I'd like to show you some surgeries, the extraoral methods. Do incision under the angle of the mandible about 3 centimeters. After that, making, we do corticotomy, vertical corticotomy in removing cortical slice of the jaw, keeping mandibular nerve and vessels. After that, and disposition this cortical bones. Also the left side. You can see here the corticotomy. After that, about the 1.5 centimeters removing. This is during the surgery when do double side of corticotomy, vertical corticotomy. You can see the right position of the jaw and the splint, which planning before the operation, and also fixation. You can see fixation the right side, and all changing the chewing. After that, after reposition, we're fixing them with the mini plates, And it was first method, extraoral method. Also, I would like to show you the intraoral method. You can see the big deformity of the jaws, mandibular macrognathia. It's MRI investigation. You can see the big mandibular jaw, and it's intraoral. The Dal Pont methods of osteotomy, vertical osteotomy, sagittal osteotomy. After that, we can the corticotomy. After that, you can see here the position, the chewing in right position. This is scheme. On the scheme, you can see here the corticotomy on the angle and mandible. After fixation, before and after surgery, you can see the right side and back, front side and back side. Also, some defects, deformities of the jaws. The indication of the surgery is bimaxillary osteotomy. Bimaxillary osteotomy for deformities with more than 3 centimeters, we do bimaxillary osteotomy. For bimaxillary osteotomy, we do osteotomy, the vertical, horizontal osteotomy of the leafward one, the maxillary bone. This is before. You can see here big deformity of the lower jaw and the small maxillary bone. And this is maxillary bone. It will osteotomy, and the second, the osteotomy of the vertical of the mandible. Also before, so after surgery, you can see here many places with fixing not only mandible, also maxillary bones. Before and after, you can see here the front and subeus. Also, like deformities, not only macrognathia, also we have patients with suffering with macrognathia. So you can see here the very small mandibular jaw. Also, for mandibular jaw, you can see here mandibular nerve and mandibular vessels we keeping on the one internal cortical bones. This like corticotomy, after corticotomy, so moving the mandibular to front, 1.5 or 2 centimeters. After that, you can see here fixation of the right side and fixation between the cortical bones. You can see fixing additional bone for repositioning. Also, we do in these patients mentoplasty, removing the mental bone to front for 1-2 centimeters and fixing it with mini plates. You can see here after the surgery. After the surgery, this is MRI investigations, and before and after surgery. Also, the patients before after surgery, the maxillary. So before after surgery and before after surgery. From 2008 till now, we did about 1,000 surgery young patients who suffer these joints. Thank you very much.
Thanks a lot organizers. Thanks sir for giving me this opportunity to share a little bit about oncology over here today. So I'll begin. I'm a medical oncologist. So I'll begin with one question. And I'd like to see a raise of hands. How many of you have seen a cancer patient, or how many of you have heard of someone getting diagnosed with cancer? Just a raise of hands, please. None of you You don't know about anyone in your neighborhood, in your family, or in your friend circle, anyone getting cancer? Okay, fine. So today, we all know that the incidence of cancer is increasing. The number of patients getting diagnosed with different types of cancers is increasing. So I'll be speaking a bit about how the science of oncology is improving. So whenever we come across a cancer patient, whenever you meet someone who's got cancer as a doctor, the questions that are raised to you are, how long will I live and how good will I live? And that's what we need to look for. That's what we as doctors, you all as students and doctors, need to have the answers to this question. And that answer till a decade ago or till 2 decades ago was very dismal. The quality of life as well as the duration of life of cancer patients was very short. But fortunately, the science has advanced. We have now newer treatments, newer technologies, newer medicines, which are improving not only the duration of life, but also the quality of life of each and every cancer patient. And that's what we'll be seeing in a few graphs over here. So this is the question that we are beginning with, and maybe at the end of my 15-minute talk, you will be able to answer it in a better way. I'll begin with one simple case. This is X-ray chest of a patient. You can see a large patch over here in the right lower lobe, and this is a patient and this scan was done on 11th of November. The same patient on 16 November, this is the scan. So same patient, 5 days, 11 November, 16 November. This is the difference. What do you think changed this? What do you think made this patient who was oxygen dependent, he was in the ICU, in the intensive unit, come out in the ward and go back home and do his job? And that too in just 5 days, 11 November, 16 November. This wasn't a miracle. This wasn't any big thing. This was 1 tablet a day. Just single tablet of a targeted therapy, single tablet of osimertinib. The drug which we gave this patient was osimertinib, 80 milligram of osimertinib for 5 days, and the chest X-ray cleared off. The patient went home, and he is still doing good on 1 tablet per day. So that's the beauty of medicine. From this case, so this is the drug that I mentioned, and this is the data that I'm showing now. So I'll be showing a few graphs, a few trials which have been done. So osimertinib, when given to lung cancer patients, it's a targeted therapy useful in EGFR positive lung cancer patients. So a bit of a molecular jargon here. So epidermal growth factor receptor is mutated in almost 30 to 40% of lung cancer patients. And all of those benefit with this single tablet. You can avoid chemotherapy. You can, just after surgery, you've done surgery for a stage 2, stage 3 lung cancer patient. You give this osimertinib for 3 years, and you have 85% patients surviving at 60 months. That's 5 years. So a stage 3 lung cancer patient has 85% chance of living a normal life beyond 5 years. And that's what we call as cure in cancer. Similarly, there's another drug named durvalumab. Now this is immunotherapy. As students, some of you would be learning in pathology and again further in medicine and during your oncology postings that there is something which is immunotherapy and that's advancing or improving our outcomes in a significant manner. Again, stage 3B is sort of an advanced lung cancer where surgery also cannot be done. And in such patients, if after you do chemotherapy and radiation for 1.5 months, and after that the patient is given durvalumab. This particular medicine is just given as a single saline once in 3 weeks, and you give it for another round of 17 sessions, you improve the survivals by almost 10 to 15% or even more. And if you see, the median 18-month PFS in such a high-risk population is 44%. The next is alectinib, ALK-targeted therapy. So ALK is another gene which is mutated. There is fusion of ALK gene happening in lung cancer patients. And with using alectinib post-surgery, you can improve the survivals by almost 30%. So people who received surgery followed by chemotherapy, at 3 years, 53% were disease-free. Those who received alectinib, 88% were disease-free. And this is irrespective of the stage. So if you see stage 1B, stage 2, stage 3, with the chemotherapy, those who received chemo, their outcomes went on dipping down after the surgery or after chemo. Those who received alectinib, 92% of patients are doing well and disease-free at 2 years and 3 years. So another wonderful drug. Now this is the CROWN trial. Another drug, lorlatinib, stage 4 patients, brain metastasis. Brain mets a few years ago, cancer going to the brain was equivalent to facing death. Today, 60% of those patients can be alive and doing well and actually rocking at 60 months. So that's another wonderful drug. Stage 4 lung cancer patients, 60% alive and doing good at 60 months. That was about a lot of targeted therapy in lung cancer. In cervical cancer, cancer of cervix, a mild change in the strategy. Till just 2-3 years ago, the best treatments for cervical cancers were combination of chemotherapy and radiation. Today, what we do is we give induction by just 6 small doses of chemotherapy, which is very well and very easily tolerated by the patients, and that is followed by radiation. And with this small shift in strategy, you improve the disease-free survival by another 10% at 5 years. In addition to this, there is a recent trial which showed adding immunotherapy to this combination of chemo and radiation, you get another 10% patients surviving and doing well and completely cured of cervical cancer. So all these stats are showing that yes, more and more patients can be cured. More and more patients can be living normal lives. Niche 2, so lung cancer, cervical cancer. Now we move on to the colon cancer, cancer of colon. So there is a subgroup of colon cancer patients, around 15 to 20% of colon cancer patients will have a particular genetic defect, a mismatch repair defect, and that induces the cancer formation in those patients. If you just treat those patients with 2 sessions of chemotherapy and then subject them to surgery, that's what was done in this particular trial, you see that all the 100% patients have got a good response. Out of those, 79% patients had complete pathological response, which means not even a millimeter of cancer was there in their colon with just 2 doses of immunotherapy. So that improves the survival, and the same patients at 3 years, 100% of them, just a flat line at 100%, having a completely disease-free life just with 2 sessions of immunotherapy and a surgery. No chemotherapy, no radiation. That's how we improve the outcomes. Another trial of dostarlimab, again an immunotherapy agent, no surgery, no radiation, just 6 doses of immunotherapy. All 12 patients, complete response and no disease recurrence. So without getting a single incision, without getting any burn, you are curing the patient. Coming from solid tumors to hematological malignancies, Hodgkin's lymphoma, stage 3, stage 4 Hodgkin's lymphoma, till around 3-4 years back, the cure rates were in the tune of 70%. Now, with the addition of brentuximab vedotin. So BV is a targeted therapy, N is nivolumab, that's immunotherapy. So this trial was done between immunotherapy versus targeted therapy, and the winner over here was immunotherapy. So 92% of patients of Hodgkin's lymphoma stage 3, stage 4, where your cure rates were not that good, now they are living a normal life. So this was about the targeted therapies and immunotherapy. That's how they are improving with the help of those particular medicines, we are improving the outcomes. Almost 85, 90, 92% of patients, and in some cases even 100% of patients getting complete responses. But what beyond that? Are all cancers being treated or being cured with these medicines? No, not yet. So we need some technology, some treatment beyond this. And then there comes the CAR T cell therapy. So what is CAR T cell therapy? So CAR T is chimeric antigen receptor T cell. So a patient's T cells, so this is a leukemia or a lymphoma patient, so a blood cancer or a lymphoma patient who has whose disease did not respond to the conventional chemotherapy, whose disease did not respond much to the targeted therapies also. So for such a patient, you collect the T cells, you do leukapheresis, you collect the T cells, you genetically get them engineered by insertion of the antigen. So you know what antigen is being expressed by the cancer cells. The CD19 is one of the common targets that we use in CAR T cell therapy for lymphomas and leukemias. So that particular antigen is inserted into the patient's T cell, so that the T cell becomes activated specifically against the CD19 expressing cells. And these CAR T cells, they undergo expansion in the laboratory, and then millions of CAR Ts are then administered just like a blood bag to the patient. And once that is done, then the T cells attack the cancer cells in a very targeted fashion, targeted manner, and destroy the cancer cells. And this, another picture showing the same, that the viral DNA is getting integrated into the T cell of the patient, and then that leads to the expression of the chimeric antigen receptor. So this is the antigen which is being expressed by the tumor cell, by the cancer cell. And you have this particular expression on your own T cells, which now go and generate an immune response against the cancer cell. So this is how the CAR T cell therapy works. Now coming from theory to the real world, this is a paper from India. This is the CAR T cell therapy, CAR T, which was developed in India. And this is the study from our place. So if you see, the patients with refractory and relapsed B cell leukemias and lymphomas, 73% of the patients had responses. As an oncologist, I can tell you, in any other treatment for such a patient would have given response rates of just 5%, 10%, or at the most 15%. And the responses are not durable. They are not long-lasting responses. The responses which we got with the CAR T cell therapy were not only good in the tune of 70 to 80%, they are also durable. People with just one session of CAR T cell therapy have got near complete responses, and they are living again like others' normal life. So that's what is the latest in medical oncology. That's what is CAR T cell therapy. So what beyond medical oncology? I'm an oncologist. I'll go a little beyond us because I'm here to speak about cancers. So Dr. Grant mentioned cyclotron. So cyclotron was installed at Ruby Hall, and with the help of cyclotron, there are multiple radionuclide targeted therapies which can be prepared. So what we do is, we do PSMA. PSMA is prostate specific membrane antigen, and this particular antigen is expressed only on prostate cells, prostate cancer cells. So when you combine this, when you do a PSMA with gallium-68 or PSMA with lutetium-177, then a patient who's got this disease burden and who's previously been treated with surgery, chemotherapy, hormonal therapy, and all sorts of treatments, in whom there would have otherwise been no hopes, gets this kind of a response. So that is PSMA PRRT, peptide receptor radionuclide therapy. So this is one case. This is just another one. Multiple metastasis, prostate, though it's a small lesion, but multiple bones involved, multiple lymph nodes involved, almost everything cleared off. So this is in prostate cancer. Similarly, we are using PRRT in neuroendocrine tumors. Neuroendocrine tumors are intrinsically resistant to chemotherapy, immunotherapy, or many other treatments, or most of the other treatments. Someone who's got such a big lesion in the liver would not be even fit or would not be able to undergo surgery, because surgery would mean a complete liver removal or at least a liver transplant. In such a patient, you give DOTA-based, DOTA is another antigen to, again, lutetium-177 is a radioactive material which is bound to the DOTA, and DOTA-specific therapy or DOTA-targeted therapy, that's the PRRT, a few sessions and the complete response over there. Another case from our institution, such a big disease, after a few sessions, and then later on. So complete responses or near complete responses, and that too with minimum toxicity, that too with minimum deterioration in the quality of life. So that is what we as doctors want for our patients, and probably we are getting that for many of us. This is this is a waterfall plot showing that 90% of patients with who have been subjected to PRRT, they get responses. There are 10% of the patients who may not respond. The target may not be hit properly, but then so 90% is the response rate for PRRT. So what are the graphs telling you? What do you think? After going through all these graphs and images, what do you think of science, or what do you think of oncology now? And what will you be telling your patients tomorrow in your clinic? So that's what I wanted to show you. And what should we expect for our long-term survivors? Can we improve their long-term quality of life? Definitely yes. We can improve their duration of life. We can help them improve their quality of life as well with the help of all these newer treatments. And finally, a thought-provoking or something to ponder about after listening to all the talks given over here today. Are we coming here? With that, I'll end my talk. Thank you.
Assalomu alaykum. Profi Universitet rektorat xodimlariga, talabalarga, hamma ustozlarga men birinchi bo'lib o'zimni minnatdorchiligimni bildirmoqchiman. Shu konferensiya, xalqaro konferensiya tashkil qilinganiga va bizni mehmon sifatida chaqirganingiz uchun katta rahmat. Dear colleagues and guests and conference organizers, I am pleased to welcome you. I am proud to represent our country at this international conference. Today I present our report in Russian, but all the slides will be in English for our guests. Здравствуйте, уважаемые коллеги, студенты. Хочу выразить свою благодарность всем организаторам, а также ректорату Профи Университета, что они предложили мне быть лектором в этом университете. Это большая честь для меня, но основная моя работа – это Ташкентский государственный медицинский университет. Я в данном институте, хоть он и менял свои названия 3 раза, работаю с 2004 года, преподаю в данном университете и защитила там и кандидатскую, и докторскую диссертацию свою. Сегодняшний доклад я выбрала специально такую тему. Вообще я, как и наш ректор, который является для меня большим примером, Баймурадов Шухрат Абджалилович, он был проректором по науке, когда я защищала свою докторскую диссертацию, он нас поддерживал и показал пример, что настоящий врач, он занимается и практикой, и наукой, потому что практика без науки или наука без практики – это не совсем полная медицина, которую мы должны оказывать нашему населению. Поэтому выбрала такой доклад, который будет не совсем стоматологический, который будет интересен для врачей и также для стоматологов. И сегодня я хотела бы доказать нашим студентам стоматологического факультета, что стоматолог – это не просто зубной врач, а стоматолог – это врач, который должен уметь вовремя распознать и оказать квалифицированную помощь нашим пациентам. Стоматология – это не только про эстетику, стоматология – это не только про деньги. Стоматология – это про сохранение функций, важных функций нашим пациентам. И мы не должны об этом забывать и должны впереди всего ставить интересы наших пациентов. Данная тема, она практическая. Сегодня я показываю практическую часть, но мы ее научно изучаем, потому что сегодня современная стоматология, она настолько идет быстро, очень много новых методов, очень много новых материалов, конструкций протезов. Поэтому наша тема развивается совместно с Южноуральским государственным медицинским университетом, с профессором Нуриевой Натальей Сергеевной, и нашими аспирантами мы совместно проводим эти работы. Вы знаете, что за последние десятилетия в области онкологии и вообще челюстно-лицевых каких-то повреждений очень медицина хорошо развивается в различных направлениях. Есть очень много методов и оперативных, и терапевтических, и восстановительных в данном направлении. Это, конечно же, в совокупности определяет актуальность данной темы. Когда у пациентов повреждения челюстно-лицевой области возникают задачи послеоперационные, когда мы должны восстановить пациенту функции поддерживания мягкой ткани и в то же время с закрытием операционной раны и дальнейшим кормлением пациентов. То есть у пациента должны восстановиться функции питания. И, конечно же, в большинстве случаев на ранних стадиях, когда мы оказываем ортопедическую помощь пациентам, я имею в виду ортопедическую, стоматологическую помощь пациентам, мы, конечно же, помогаем этим пациентам быстрее вернуться в социум, что очень важно для пациентов. Представляете, когда пациент, он не может функционировать как обычный человек. Одно время такие пациенты просто заперлись в доме, и от того, что они не могли выйти и полноценно жить с остальными людьми, показываться в социуме, их уровень жизни, качество жизни понижалось, и, конечно же, продолжительность жизни снижалась. На сегодняшний день, несмотря на то, что исследования в данном направлении развиваются, но остается открытыми много вопросов. Какой же метод протезирования таким пациентам выбрать? Какой же тип материала? Какой же тип конструкции выбрать этим пациентам, потому что на сегодняшний день таких конструкций очень много. Посмотрите, пожалуйста, на данный слайд. Большинство пациентов с опухолями челюстно-лицевой области – это пациенты визуальные. Что значит визуальные? То, что мы можем увидеть это невооруженным глазом. Конечно же, широкий охват занимает то, что мы должны заняться плановой санацией полости рта. То есть пациент в первую очередь переходит куда? К стоматологу, если у него возникают какие-то проблемы в полости рта. Плановая санация, она очень важна, потому что ранняя диагностика таких заболеваний на ранних этапах помогает нам вовремя помочь пациенту и, конечно же, продлить его жизнь. И главными задачами стоматолога здесь является, конечно же, в первую очередь, это профилактика и онконастороженность. И это я говорю всем молодым специалистам. Вы не просто ставите виниры, вы не просто ставите имплантанты. Вы внимательно относитесь к каждому пациенту и на ранних этапах выявляете и отправляете этих пациентов по направлению. То есть в онкодиспансер, в онкоклинику, к хирургам-стоматологам. И сегодня вот как раз-таки такие темы были затронуты на данной конференции. И вы знаете, по данным нашего анкетирования, мы это сделали, профессор Нуриева сделала это в России, мы сделали это на территории Узбекистана. И примерно одинаковые цифры вышли, что 30% пациентов, они в первую очередь приходят к стоматологу с такими проблемами. Они говорят: доктор, у меня, вы знаете, на щеке какие-то высыпания. Доктор, вы знаете, у меня во рту какая-то сухость. Доктор, вы знаете, у меня на языке что-то появилось. Это вас должно насторожить. Обязательно. Потому что вы врачи. Для лечения рака головы и шеи в настоящее время применяется много разных методов лечения. Вы знаете, да? Это может быть лучевая терапия, это хирургическое вмешательство, это химиотерапия. Но, однако, пройти все этапы специализированной помощи, когда это в челюстно-лицевой области, без ортопеда-стоматолога представляется невозможным, так как пациенту нужно помочь, опять-таки, повторяюсь, восстановить функции приема пищи и разговора. В чем заключается первый этап помощи? На сегодняшний день и ранее, когда я работала в поликлинике хирургической стоматологии, что мы делали? Мы снимали слепки до операции. Да? Слепки, оттиски, как хотите их называйте. Да? Мы снимали их различными материалами. Для чего? Для того, чтобы отлить диагностическую модель и вместе с хирургом-стоматологом определить границы нашей операции будущего протеза. Что делалось в первом случае? При первом методе протезирования мы снимали слепки и заранее изготавливали протезы, и непосредственно после операции мы накладывали эти резекционные протезы. При втором методе, это после операции, примерно через 2-3 месяца после эпителизации нашей раны, мы изготавливали протезы пациенту. Один метод, первый метод, он лучше. Почему? Потому что когда мы изготавливаем резекционные протезы непосредственно после операции, что мы делаем? Мы уходим от рубцевания тканей. С другой стороны, когда мы накладываем сразу протез, он не всегда бывает точный, потому что после операции, возможно, не будут те же самые точные границы, как мы делали это на модели. Конечно, более точные будут протезы, которые будут после эпителизации раны, но здесь мы не можем избежать рубцевания наших тканей. То есть на сегодняшний день у нас и те протезы имеют свои минусы. Значит, первый этап – это подготовка фиксирующей пластинки. Второй – это резекционная часть протеза. В таком виде протез будет считаться временным, потому что он резекционной тканью у нас восстанавливается. И третий – это обтурирующий протез. Мы можем сделать его из временного резекционного протеза, а можем изготовить новый постоянный протез. Вот посмотрите, резекционный протез, что он позволяет? Он позволяет нам избежать зондового питания, то есть мы закрываем полость носа и рта, да, мы делаем границу, поэтому исключается зондовое питание, пациент может нормально, как обычный человек, принимать пищу. И также мы можем с помощью этого протеза удерживать какие-то лечебные повязки. И, конечно же, одна из самых важных функций, мы восстанавливаем здесь функцию дыхания и речи. Вот здесь посмотрите на данном слайде очерчены границы протеза. Границы будущего протеза и резекции это делается обязательно вместе с хирургом-стоматологом. Отдельно ортопед-стоматолог, либо отдельно хирург-стоматолог, онколог-стоматолог это сделать не может, только все вместе. И, конечно же, конструкцию протезов и материал пластин мы обсуждаем вместе с хирургом-стоматологом. Согласовываются также дополнительные элементы для удержания нашего протеза. Видите, здесь изготовлен резекционный протез из бесцветной пластмассы, который имеет менее химических реагентов, таких как красители и другое, и более приятно в носке. Да, она, может быть, эстетично не повторяет цвет десны, но, тем не менее, она имеет меньше токсического влияния на мягкие ткани. Также мы здесь вот видите, вместе с хирургом обсуждается конструкция будущего протеза. Вот. Также мы можем при полном отсутствии зубов согласовать с хирургом-стоматологом о том, возможно ли использование дентальных имплантантов. К сожалению, точность наложения протеза не всегда соответствует определенной клинической ситуации, как я до этого сказала. Так, я, кажется, назад. На сегодняшний день направление цифровой стоматологии помогает нам избежать многих неточностей. 4 года назад, в 2021 году, мы на нашей кафедре открыли предмет цифровой стоматологии. На тот момент я еще думала, правильно ли я сделала, нужна ли цифровая стоматология в нашем вузе, нашим студентам или нет, потому что цифровая стоматология на тот момент была слабо развита в Узбекистане. Прошло всего лишь 4 года, и цифровая стоматология вошла в повседневную жизнь стоматологов почти что 70% стоматологов Узбекистана. Поэтому мы на правильном пути, и цифровая стоматология помогает нам не только создать красоту пациенту, но и, конечно же, создать более точные протезы, выбирая новые, эффективные, удобные методы для протезирования наших пациентов. Вот. И протезы после того, как появилась цифровая стоматология, они стали более точными. Сейчас при наличии интраоральных сканеров мы можем прогнозировать точные границы нашего протеза. Один из важных этапов является создание диагностических моделей. Да, как мы говорили, мы снимали слепки, отливали модели. А сегодня мы можем отсканировать, определить уровень границы нашего дефекта, и дальше с помощью цифровых протоколов и моделирования, все виртуально, мы можем создать прототипы наших будущих протезов. Так, на данном слайде у нас представлен обтурирующий протез с мягкой прокладкой и с удерживающими кламерами, а также металлическим каркасом. Данный металлический каркас, когда я читала лекции студентам буквально 10 лет назад, мы говорили, что у нас существует только один метод изготовления металлического каркаса – это изготовление каркаса с помощью литья. Да? Мы отливали металлы. На сегодняшний день у нас есть 3 метода. Это также остается литье, которое мы до сих пор используем. Появилось фрезерование с помощью CAD-CAM-систем. И, конечно же, появилась 3D-печать лазерного спекания. Мы ее ЛСП называем. И с помощью... У нас в Узбекистане тоже уже есть такое оборудование, которое может нам изготавливать 3D-печатные металлические конструкции или поддержки наших протезов. Видите, какие дефекты бывают у пациентов после хирургических вмешательств. У наших пациентов после хирургических вмешательств возникают еще плюс контрактуры, которые не дают открывать хорошо рот, и очень сложно оказывать помощь ортопедическую таким пациентам. Здесь пациенту предлагается массажи, миогимнастика, функциональная гимнастика. Как мы контролируем положительный эффект, который мы добиваемся от таких пациентов, это с помощью цифровой аксиографии. Аксиография – это старый функциональный метод. Когда мы учились, у нас на кафедре были старые аксиографы, а это были аналоговые аксиографы. С помощью чернил у нас рисовались графики на бумаге. На сегодняшний день мы все это производим в цифровом формате. Мы видим движение сустава. А если мы к нему подключим миограф, мы еще будем видеть функции наших мышц. На данном слайде представлен клинический случай пациентки из Нукуса. Это Республика Каракалпакстан в Узбекистане. Пациентка, к сожалению, после бифосфонатного некроза. Здесь я еще раз хочу сказать нашим студентам, здесь была допущена большая ошибка врачей, которые, не собрав полный анамнез у пациентки, не узнав, на каких препаратах пациентка находится или находилась, удалили один зуб, потом второй зуб, и у пациентки начался бифосфонатный необратимый некроз. Буквально год челюстно-лицевой хирург наш в Ташкенте боролся за эту пациентку, убирал некротизированную ткань до тех пор, пока процесс не остановился. После того, как процесс остановился, хирург направляет эту пациентку к нам в клинику вот с такими дефектами. Пациентка нормально не может принимать пищу, у нее все выходит через нос, не может нормально разговаривать, и, конечно же, она выпадает из социума. Я не пугаю студентов, я призываю всех студентов быть весьма настороженными и внимательными к каждому пациенту. Что мы делаем? Мы снимаем слепки с помощью альгинатного материала. Этот материал очень удобный, у него один большой минус, он дает быструю усадку, поэтому мы должны очень быстро отлить модели. Но он мягкий, и снять атравматично слепки удается с помощью этого материала быстро и удобно. Отливаем диагностические модели и видим дефекты на верхней и нижней челюсти. Очерчиваем и с зубным техником моим обговариваем конструкцию будущего протеза. По этапам изготавливаем вот такой протез, который является формирующим, потому что пациентка обратилась ко мне уже после эпитализации, ее направили, поэтому мы изготавливаем сразу постоянные формирующие протезы. Вот так это выглядит в полости рта. Видите, мы изолировали полость рта и носа друг от друга, и пациентка свободно может принимать пищу. Так, можно видео поставить? У меня вот здесь под слайдом видео, но я не знаю, как это сделать. Первое и второе, тут два видео. Если будет слышно. Не слышно, да? Сейчас слышно. Угу. Сперва первое поставьте. Я хочу, чтобы вы послушали, как пациентка разговаривает до того, как мы изготовили ей протезы, когда она к нам пришла. И после того, как мы изготовили ей протезы. Мало того, что пациентка переживает, женщина, такую вот эстетическую проблему, да, у нее еще и функциональные проблемы. Не получается? Пациентка замужем, у нее ребенок, несмотря на это все. Теперь второе. Первый раз пациентка говорила, ее невозможно было понять. Второй раз уже все слова мы можем различить. То есть пациентка возвращается к полноценной жизни. Сейчас еще вот здесь тоже так же. И еще на примере одного пациента.
28 ноября 2022 года на улице Тюрьма.
Одну пациентку принимали мы в Узбекистане, другая пациентка была принята в России. То есть одни и те же проблемы в наших странах возникают, и мы стараемся совместно двумя коллективами реабилитировать таких пациентов, потому что, к сожалению, не все стоматологи хотят возиться с такими пациентами. Все, теперь следующий слайд можно? Так, то есть мы сканируем и изготавливаем вот такие обтурирующие протезы не только после онкологии, но и после других вмешательств хирургических в полости рта. Для того, чтобы дальше работать с другими зубами, нам необходима обтурация. Потому что без обтурации мы не можем дальше работать, потому что, вы понимаете, опилки, воздух, все будет попадать в полость носа. Вот такие мини-обтурирующие протезы можно изготовить с помощью современных материалов, с помощью 3D-печати. Есть силиконовые, мягкие протезы, которые очень удобные, и микропротезы носки. Пациентка уже, это Нуриевой Натальи Сергеевны, проведена в полном цифровом протоколе, ей проведено лечение, был сделан smile дизайн, то есть пациентка требовалась не только восстановить функцию, но она и хотела восстановить еще и эстетику. Вот такие протезы из такой хорошей пластмассы были ей изготовлены. Здесь я не буду ставить вам видео, здесь точно так же пациентка разговаривает. Ну ладно. Давайте послушаем и... Переключить можно дальше? А то у меня опять видео будет. Нет, все. Но пациенты не всегда приходят к нам с большими дефектами. Бывают пациенты вот с такими маленькими дефектами. Из-за таких маленьких дефектов пациенты не хотят идти на хирургические вмешательства. Тогда мы, как настоящие врачи, принимаем решение помочь этому пациенту и изготавливаем такие протезы, маленькие, комфортные, которые закрывают дефекты пациента. У пациента не становится сообщения между полостью рта и полостью носа. Есть вот такие обтурирующие протезы, они на металлическом каркасе, это формирующие, обтурирующие протезы. Мы от них не отказались, это наши любимые бюгельные протезы, которые очень долгое время служат нашим пациентам. И металлический каркас, он не изменяется, и при формировании мягких тканей мы можем корректировать нашу пластмассу, либо быстро твердеющей пластмассы в клинике, либо уже в лаборатории. Иногда мы прибегаем к помощи имплантации, потому что после операции, когда хирург или же онколог, стоматолог разрешает нам прибегнуть к имплантациям для того, чтобы протез удерживался, стабилизировался и фиксировался в полости рта, потому что мы видим, на такой плоской площадке никакой съемный протез удерживаться не будет, мы устанавливаем имплантанты, делаем санацию, удаляем ненужные корни, и устанавливаем мини-имплантанты, потому что обычные имплантанты установить в дефиците костной ткани не представляется возможным. Сохранились верхние корни 2, и внизу установились 2 мини-имплантанта, и пациенту наверху фиксируется на 2 наших 13 и 23 зубе, а внизу с помощью установки мини-имплантантов с болл-абатментами. Без хирургического вмешательства не всегда приходится нам помочь пациенту, поэтому мы работаем в комплексе, в бригаде с хирургами-стоматологами, с челюстно-лицевыми хирургами, такими как наш ректор Баймурадов Шухрат Абджалилович. У нас еще есть и другие хорошие ведущие челюстно-лицевые хирурги в Узбекистане, которые помогают нам, ортопедам-стоматологам, в дальнейшем восстановить функцию оживания и другие функции человека. И на сегодняшний день, конечно же, комплекс хирург-стоматолог, ортопед-стоматолог и современные методы цифрового направления стоматологии помогают нам добиться совершенства. Мы делаем индивидуальные протезы на таких болл-абатментах, и пациент спокойно носит. Они удерживаются, хотя вы с левой стороны видите, что часть тела нижней челюсти была резицирована. Не всегда мы можем использовать цифровые протоколы. На сегодняшний день основная масса сканеров, она не может просканировать глубину. Когда у нас мешает язык, мешает щека, нету достаточной костной опоры, много мягкой ткани, к сожалению, сканер не может точно отсканировать. Тогда мы не забываем о том, что у нас есть и аналоговые протоколы, и снимаем слепки. Снимаем слепки и не отказываемся от наших старых конструкций, металлокерамических, бюгельных конструкций, потому что мы знаем, что когда у нас невозможны цифровые протоколы, мы можем прибегнуть к аналоговым протоколам. Поэтому мы учимся всегда новому, но не забываем о старом. Поэтому, когда студенты спрашивают у меня, а зачем нам проходить эти конструкции протезов? Они же сейчас не изготавливаются. Вы знаете, в своей практике вы можете использовать любую конструкцию протезов. И своим студентам я говорю, стоматолог – это не просто врач, который прочитал по книге и делает. Каждый врач должен подходить к каждому пациенту индивидуально, не по книге. Вы берете за основу, за фундамент то, что написано в книге, а для этого у вас есть голова, для этого вы не искусственный интеллект. Вы врач, вы художник, который работает к пациенту, и вы обязаны, если он к вам пришел, помочь ему максимально. Вот такой протез мы изготовили с помощью аналогового протокола, сделана искусственная десна, установлены имплантанты. Этому пациенту мы не можем сделать костную пластику, мы не можем сделать мягкотканную пластику в силу показаний по здоровью, поэтому мы стараемся любому пациенту нашему помочь. Спасибо большое за внимание. Я думаю, что... На странице своей в Инстаграм я готова отвечать на все вопросы и студентам, и преподавателям. Я открыта к общению. Спасибо еще раз.
Profi University Bektemir va ta'sischini taklif etamiz.
Now, I will invite to the stage the director and the founder of Profi University.
Dear guests, esteemed guests, thank you very much for good cooperation. First of all, it was a very fruitful collaboration, and we appreciate all you come, all
your experience that you share with us. And that's why it's not only about the conference, but it is a starting point of the first Uzbek and Indian collaboration in medical, and not only in medical, but also in cultural development of our nations, our countries. And thank you very much. That's why we are going to help you honor professor, to our esteemed guest, distinguished guest, as an honorary professor of Profi University. We are going to invite Dr. Grant. Grant. Dr. Grant, you are now honored professor of Profi University. Now, honored Professor Himish Ramesh Gandhi of Profi University. Thank you very much, Mr. Gandhi. Yeah, it was a pleasure to
Dr. Chakrasyukhi Vora.
Honored Professor of Profi University, Dr. Chakrasyukhi Vora. Thank you very much. You are doing a great job in oncology, and we are glad to see your experience and thank you very much for sharing your good expertise. Thank you. Honorary Professor Rizaya Sivaramuglamna. Спасибо, что вы есть у нас. Спасибо, что вы...
Выражаем глубокую благодарность от имени ректората, от имени учредителя, от всех профильного состава за прекрасные содержательные доклады наших гостей из Индии и наших коллег с Ташкентского государственного медицинского университета. Спасибо.
Dear guests, students, all the participants, this kind of event, this kind of occasion will not be possible without the help of Mr. Urbash. But thank you very much. You are doing a great job. Actually, man should have two things right in their life. We have talked about this with Ms. Rugrant yesterday. First is a right choice of profession, and the second, the right suppose. And Ms. Rugrant, you did both two of them very brilliantly. Thanks to Mrs. Jill Grant, thank you for accompanying us, and we are glad to see you. And thank you. And our esteemed guests, all of that, all things that happen for one reason. Someone will be the reason for good collaboration and good relationship. And for all of this kind of occasion will not be possible without the head and founder of Walnut Group companies, Sandeep Singh. Sandeep? Yeah, Sandeep. Sandeep, very good friend of Profi University, and he is our colleague and partner. And thank you for introducing us at Ruby Hall and Rubicon Clinic, and thank you for introducing me with the Indian culture, Indian business, and Indian clinics. Thank you very much. And thank you also for Rishi. Rishi, thank you very much. You are doing great job on the international level. It is, as I before mentioned, it is a starting point of our great collaboration. It is a starting point of our journey in medical collaboration. That's why we are only starting. Thank you very much. Thank you for all participants. We have a famous phrase, we are glad to have you. Thank you.
Данная конференция проходит в университете Профи. И вы видите сами очень успешно. Но поскольку мне хотелось бы прежде всего еще раз уже не как медик, а как психолог напомнить, все, что мы добиваемся, мы прежде всего должны своим родителям, своей семье, своим, прежде всего кому? Это предкам. Прежде всего нашим родителям, нашей семье. И поскольку учредитель организовал, учредитель сделал все для успешной конференции, хотелось бы сюда пригласить ради аплодисментов родителей учредителя. И что бы ни делал супруг, всегда в его успехах немалая доля супруги. Мархамат. Вот теперь аплодисменты этой прекрасной семье.
Thank you very much. Thank you, my father, mother, I suppose, and thank you all the guests, all the students, and we are going to do our best to foster this kind of collaboration and to fulfill your dreams with the reality. Thank you very much.
Нашей молодежи, нашим студентам, чтобы у вас были такие счастливые семьи, чтобы у вас были такие счастливые, успешные дети. Спасибо вам. И чтобы вы в самое ближайшее время достигли тех высот, которые сегодня продемонстрировали наши лучшие ученые и практики, наши ученые Индии и Узбекистана. Спасибо.
The group photo, please come and group photo. Yeah, please come. Group photo.
yaxshiyam borsan. Profi University